People will see so many slides, Jason.
Okay.
So
All
I'll
right.
just stop briefly. Otherwise, time might be an issue.
No problem, babe. Thank you.
Okay. Greetings, everybody, wherever you are, and it's wonderful to have you join us for this first webinar of the 5 in a series. Just to kick us into this webinar session, we'll start by introducing myself. My name is Benjamin Kagina. I am the director of the NITAG Support Hub, or NISH, that is based at the University of Cape Town. And I'm sure most of you, we may have interacted in one way or another, either through email or through some of our activities that we do through the NISH project. Just first, welcome everybody, and for NITAG's EPI and partners on this webinar, feel very welcome, a very big African welcome. And we're going to start by doing very quick housekeeping. So we're going to be having back-to-back webinars, the English and the French. So the English is happening today, which is now, and there will be no interpretation provided during this webinar. It's going to be done in English. So if you are attending this webinar and you are much more comfortable in the French session, there will be another session in French, exactly the same topic being discussed. The second aspect is that you will see at the bottom of your screen, there is Q&A. As we interact, as we discuss, please feel free to post your question. We will have an expert session where experienced facilitators, you included, as NITAG members and partners, could interact, provide answers to some of the questions, add more comment, or add more clarification to issues being discussed. And just to get started, as you can see the program, I'm going to briefly talk about the journey of NIPs, which is the National Immunization Programs, looking at it from 1974, when the expanded program of immunization was launched, to date, when even the name has been changed from expanded to essential immunization program. Just a couple of things to highlight, because there's a lot we can talk about for the last 51 years. I think the key part that we need to have in mind is that when the program started in 1974, and just to mention, I'm not sharing slides, so don't say, where are the slides? I'm just talking about a few concepts before we hand over to Kamel, who is going to go into specifics of what we want to cover in this webinar series. So when the program started in 1974, especially in low and middle income countries, 6 antigens were delivered targeting 6 vaccine preventable diseases. So we're talking about diphtheria, tetanus, and pertussis vaccines, which then was a combination vaccines of those 3 antigens. Then there was a BCG vaccine provided to prevent tuberculosis. And of course, there was the polio vaccine provided, and then the measles vaccine. And over the years, new vaccines have been introduced to this program. And currently, we're talking about up to 12 vaccines being provided, or 12 antigens, you could call them, being provided in some settings. And in other settings, this could even be 10, other settings could be 15 or even 18. I think the key message is that if you look at 1974 to date, in terms of the number of antigens delivered through the program, it has actually doubled, which is quite remarkable. And what I want to discuss with you in the next 9 minutes is actually the ecosystem, or you could call it the environment, the different factors that have actually been at play in the doubling of the number of antigens that the program has provided. So one of the very key factors I'm going to talk about is the global vaccine initiatives, and there are many, right? Including the current one which we have, which is the Immunization Agenda 2030. But key to highlight is the Gavi initiative, which was launched in 2000. And this initiative was largely to address something that we still have a big problem on, which is vaccine equity. And since the program was launched, or the initiative was launched in 2000, Gavi has facilitated access to vaccines and immunization services, particularly in low and middle income countries. And the impact has been significant. That has shaped the journey of national immunization programs in a positive way, ensuring that vaccines have been made available to the children in very diverse settings that would otherwise not been able to access those vaccines. The second initiative that I need to speak about is actually the SAGE, the Strategic Advisory Group of Experts, that was initiated or launched in 1999. I think one thing I need to mention about the SAGE is that in our work with NITAGs, when we asked you, when you're making decision, where is your first point of call when you start addressing your policy question that your Minister of Health has given to you? And overwhelmingly, most of you say the first point of call is the WHO position paper, showing the impact that SAGE has had in shaping either the introduction of new vaccine or change of the dosage that the vaccine needs to be used, and including also how we advance vaccine confidence. And linked to that, the SAGE is actually the concept of evidence-based decision-making. And when we talk about evidence-based decision-making, is an understanding that became very clear as the program became more complex in terms of the number of vaccines need to be delivered, and sometimes, which I'm going to speak to later, is targeting different age groups. Then it became very clear that immunization decision need to be data-driven, need to be systematic, and need to be guided by evidence. And that brings me to 2 key global initiatives, which is the Decade of Vaccines between 2010 and 2020, and the current Immunization Agenda 2030 that we have. And the Decade of Vaccines was very, very focal in advocating for the creation and the strengthening of NITAGs, so that all countries have access to NITAGs And that meant that countries could make sure that they strengthen the immunization program with the guidance, technical guidance from NITAGs. And the key foundation for NITAGs work is the evidence-based approach. So it is pleasing, especially for Africa, to know that most countries, over 90%, are currently served by active NITAGs, and they are able to make decisions that are based on evidence to navigate through this journey of national immunization programs that keep on adding more vaccines as they become available. And for the Immunization Agenda 2030, I want to flag something that has shaped the journey of national immunization program, and that is the issue of life course immunization. And this calls for the program to not only focus to the childhood population, which was the case in 1970s, to much more broader population, indicating that vaccines are of benefit to all stages of life, which is the life course immunization. Again, that brings some complexity in taking into account evidence, taking into account delivery of vaccines, and taking account to who to target and how to communicate to the people we need to target. The second part I want to mention as part of the ecosystem shaping the journey of the National Immunization Program is the issue of outbreaks and emerging infectious diseases. And currently, the continent in Africa, we do have Mpox outbreak, but we've seen many other outbreaks, which includes Ebola and the pandemic which we had. Having a huge stress test to the national immunization program. In many ways, there has been some positives. For example, being able to be more agile, being able to actually develop new vaccines, for example, the Ebola and Mpox vaccine, also COVID-19 vaccines, but also it had huge impact in terms of the stress on the resource allocation for the national immunization program. And this event continued to shape the journey of national immunization program. It is the same personnel, it is the same infrastructure that is used to deliver the vaccines that need to respond to the outbreaks. And then the other part I'm going to mention about the key factor is the population growth, particularly in Africa. If you look at the growth in population from 1974 to 2025, we're talking about from 400 million people in 1974 to about 1.5 billion people in 2025. That's a huge population growth, over 1 billion people. And these people need to be vaccinated. Has the health system adapted to these changes in population growth in terms of the personnel that we need, in terms of investment in the infrastructure like supply chain, financing? That is something that has shaped the journey of national immunization program. And then lastly, which is an important factor, and these are just some of the few factors that I've selected to discuss about in the context of shaping the journey of a national immunization program, is the research and development and innovation. When I started telling you about this journey, I talked about 1974 with 6 antigens being delivered by the program. Now, through research and development innovation, we have one shot which can protect a child from 6 diseases. That is remarkable. If you look at the vaccines available in terms of doses, in terms of presentation, and in terms of storage, there are more options available, much more than there were 10 years ago, than there were 20 years ago, than there were 40 years ago. And these options will become more and more important for NITAGs. For example, if you look at the UNICEF supply list, you'll see there are different types of the vaccines. For PCV, for example, you've got 4 options having different storage presentation. If you look at measles, there is potentially 2 or 3 options that are available. And all these options being available in terms of product presentation, doses, including storage, is demanding countries, and specifically with the guidance of NITAGs, to ask themselves, is what we are using now the most optimal product for our setting? And I think this is why this webinar series is so crucial, because it's going to tell us about what is available, what tools are there, partners who are there who can guide us in navigating this journey, which is becoming more complex every year. And I think as we look ahead, more vaccines will become available. There will be more effort to vaccinate everybody at all ages with the available vaccines, making it increasingly critical for us to start thinking of how do we systemize, prioritize introduction of vaccines, and how do we optimize existing vaccines? With those remarks, I'm going to now hand over to Ramonde, who is going to give us a brief explanation of the objective of the webinar, and then we get started. Over to you, Ramonde, and thank you.
Thank you, Ben, and good day, everybody. I am Ramonde, and I am a support and project lead at Niche. And we just want to welcome you all for being here in attendance. Excited as we are for joining this important webinar as we kick off the series on prioritization and optimization for vaccine schedules. So to build on what Ben has just covered, across the region, the NITAGs are being faced more and more with multiple vaccines that are all proven to be effective and beneficial. But we have the conundrum of how to introduce them. Can't all be done at once. It's really possible. So each country needs to actually balance these opportunities against the available data, the budgets, the delivery systems, and also our workforce capacities and unique country contexts. And this is really where this toolkit and orientation of this toolkit comes in. It's to encourage us to use a structured and transparent process for making decisions, these really important decisions, and make them more manageable. So you're able to actually, using the toolkit, and these are all the skills that we will unpack over the course of this webinar, you'll be able to compare vaccines side by side, weigh their relative benefits, their feasibility, and get a step-by-step process in how to actually introduce them that aligns with your national immunization strategies and our broader health system and public health goals. So this is really what this webinar series is about. We would really encourage you to attend all of the 5 in the series, and also just tell everyone in your NITAGs about that. A big part of what then happens is also just to understand how this is different from the evidence to recommendation framework. So whereas ETR supports deeper evaluations needed to make those formal recommendations, in VIPST, the toolkit will help identify which vaccines you could prioritize or optimize, how to do it, and when to do it. But using them together will ensure that the decision-making is strategic and evidence-based. So this is really about how to learn, or the process of learning how to use this toolkit, how to start applying it, learning from each other and shared experiences as we start to apply it, share our questions, and also most importantly, share our needs. And that's maybe where I'd like to just remind all the countries from our selected or targeted NITAGs to please complete the pre-session survey that was sent out, which you need to complete as a collective NITAG, and return that to us as soon as possible after the session. And we really, really want to be able to know what support you might need to implement this, whether it's data collection, whether it's communication with ministries, integrating these approaches, whatever might come up for your unique context, because that's where Niche and all our collaborating partners would like to offer utmost support. So we really hope, in summary, just that this will be a very eye-opening and practical learning space. Please bring all your questions, your comments, your thoughts to each one of the webinars. We really appreciate it, and we really, really are looking forward to going on this journey together with you and working alongside with you. And with that, I'm going to hand over to our first speaker, Kamal Sanucci. Thanks so much.
So thank you very much, Ramonde. Give me 1 second to project my slides, and so we can start. I hope that the slides are now in projection mode. Perfect. I hope you can see my slides.
We can. Thanks,
Yes.
Kamil.
Excellent. Thank you very much. So thanks, Ramonde. And Ramonde already explained who's behind this webinar. It's a collaboration under the consortium called Choices 2.0, which is managed by our colleagues from GSI. I believe Folake, Laura, you're online. And they are managing this consortium, which aims at supporting countries to do better decisions regarding vaccines in their schedule. So I'm from University of Geneva and Development Catalysts, and I'm presenting today this introduction to prioritization and optimization. This is proposed by Choices 2.0, but it's also part of a global effort that is called VPOP. I'm sorry, I'm giving a lot of names, but VPOP is a project that is led by Gavi, WHO, UNICEF, Gates Foundation, GSI Development Catalyst, and others. I'm not mentioning all of them, but that's a project that is providing support and will provide even more support to countries in this context of budget issues and better decisions. So you're going to hear a lot about VPOP in the coming month. So I'm going to start with the context that I just mentioned. Ben already mentioned a lot, and Ramonde also, that there are many vaccines options that are coming to the countries, and we are facing with a huge decrease of funding that is coming from international aid. And that put a lot of pressure on the immunization program and forced them to do some decisions. So the risk here that we can face is because of those pressure, the global funding is decreasing. As you know, Gavi did its replenishment very recently before the summer, and we got confirmation of around 9 billion support for the next 26 to 2030 Gavi 6.0 program. And unfortunately, this is 3 billion less than what was requested. We'll see also that there is a complexity of the agenda that are adding to each other. We have, of course, the WHO Immunization Agenda 2030. We have regional agendas. We have also a discussion around equity, zero dose, gender. So all that is adding on the complexity of the programs. We have a diversification of the vaccine options. You know that since Gavi launch and since for example, taking the example of PCV, since PCV was introduced as supported by Gavi, there are now many options in terms of product, in terms of presentation, in terms of schedule, which is really complex to navigate and to make a decision. We have also, and we saw the recent data published by WHO and UNICEF, the unique estimates that the coverage, the global coverage is stagnating. And in many countries, it's even diminishing compared to the pre-COVID era. And we also had all those outbreaks that are making the life of EPI immunization programs very complicated because they are arriving on top of the regular routine immunization program. We see also that there is an increased pressure regarding the financial. There is a lack of funding in many countries, and there is a need to make sure that what we get for immunization is really the best option in terms of money. And we are now using the terms, which is saying doing more with less money. So we have to look at our schedule and think about the best way to improve it, to be able to cover the needs of the population with less money. The operational challenges are also impacting the program. You have to improve the coverage, you have to introduce new vaccine, and you have to add the complexity of reaching out zero-dose children and communities and all that. So these operational costs and complexity also add up. And lastly, all of you have probably been impacted in a way or in another by the political engagement, involvement sometimes in the immunization program. Some donors, and we are all guilty regarding that, are pushing for some vaccines compared to others. You have the national politics that is also impacting the program. You have a minister coming back from a meeting and saying, okay, we have to introduce this vaccine or we have to do that. We have, of course, the pressure from the manufacturers, and lastly, the pressure from the public. So all that can lead to something that we want to avoid here is the poor decision making. A poor decision making in the sense that you do decisions that are not sustainable because you don't have the money or you don't have the human resource to sustain sometimes decision of introduction of a vaccine. We can have fragmented options because there are a lack of coordination and we are missing some opportunities. There is some backwards consultation, like the minister decides of something, and then we turn to the NITAG and to the EPR program saying, okay, so please implement that decision rather than the evidence-informed decision-making that we are trying all here to push. There are also some reactive priority setting rather than planning, better planning and long-term planning. So that's impacting a lot the program. And also sometimes we have biased decision-making because we don't have all the evidence we want, and we have still to make a decision. So that's the risk here. And the idea behind the prioritization and optimization is to try to reduce the risk of having those poor decision making. So WHO SAGE, so you know that the WHO SAGE committee is a committee of international experts that provide recommendation to WHO and to the countries, to the member states. So recently in March, there was, during the SAGE meeting, there was a discussion around prioritization and optimization. And SAGE emphasized really the need for country to really be the one making the decisions regarding which vaccine should be introduced and which vaccine could be optimized in their schedule. So the recommendation of SAGE was also that the process to make that should be country owned and happen at country level rather than regional or global level. And this decision should be using systematic approach and evidence-based. So WHO SAGE called for countries to engage their NITAG to provide recommendation on the prioritization of new vaccine to introduce and optimization of the existing schedule in support of the immunization program. And this should be integrated with the priorities that needs to be defined. Sorry, I don't know why the slides are moving alone. So this needs to be prioritized in the NIS, the National Immunization Strategy, taking into account that. So the health sector really is taking into account that. So the SAGE recommendation, I put the link here, you can go and read it to support also your activities in the country. So we want to move from the pyramids that I showed, the inverse pyramid, to that pyramid where we want countries to really have a country-owned, country-specific, unbiased, systematic, structured process, something proactive, so you're not in a reactive mode, and comprehensive. So this will help optimize the planning with a very comprehensive planning. You know where you want to go in the next few years. You can work on the financial sustainability to make sure that if you want to introduce a vaccine in 4 or 5 years, you already start working on it now. You also use this planning to improve the programmatic aspect of it. You know, for example, that you want to introduce a vaccine in 3 years, so you can start working on the programmatic aspect now, and it's embedded in the NIS, the National Immunization Strategy. So then it's linked to the budget cycles, and you can do some advocacy to make sure that the Ministry of Budget, Ministry of Finance are providing funding for those projects that you have. And it also gives at global level some signals to the market showing that the country would like to introduce these vaccines in a few years. So the market, the manufacturers know that and they can adapt their production capacity. You can also give the indication about the product that have your preference. Is it single dose? Is it a vial? Things like that. And also to give to the global level an indication of the funding needs that will be needed for that. So let's go now through some core concepts regarding prioritization and optimization. So I'm going to pause here a few seconds, and I'm going to ask you to think about those two concepts and maybe tell me what you think are prioritization and optimization. So if you have any idea and you want to take the floor, it's really informal today, huh? So don't be afraid. We are all together in this. So anybody wants to either put in the chat or raise a hand and tell me what they think is prioritization or what they think optimization is. So anybody wants to try? Don't be afraid. It's just, again, just between us, huh? So happy to take any suggestion. Nobody's raising hand. Should I take the list and ask people directly? No, nobody wants to try? Okay. So I'll ask you next steps then.
No, Kamel, there is
Oh.
a hand up from
Okay.
Sodal from Somalia.
Okay, please go ahead.
Hello.
Hello.
Good afternoon, everyone. Can you hear me?
Yes, perfectly. Go ahead.
Well, thank you, Dr. Kamel, and all other team, Dr. Benjamin and Niche team. Thank you for the webinar. I think the two things they are a bit different, and I think prioritization, if I remember, is actually it's you choose one of the vaccines. Like maybe you have 5 vaccines which are on the list, and then you prioritize according to the public health needs, and then you look for that one for evidence, and then maybe you do the recommendations as a later. But optimization is actually is like maybe you have already the vaccine in the schedule, and then you maybe you move from this one and you make changes. Like if suppose like you have a penta and then maybe you want to switch hexa, so that you move from one which has already in the schedule to another one. So it's the kind of changing optimization. Maybe you change one vaccine to the next level.
So
So that's what I mean. Thank you.
thanks, Dr. Ali. Thanks very much. And thanks for being brave to try. That's good. Anybody else wants to add something? I don't see the hands. Okay, so for sake of time, but I'll come back to you asking questions later. So, Dr. Ali, you were correct. So the prioritization is to discuss vaccines that are not yet in your immunization program, vaccines that are not introduced yet. So you want to consider the future. What vaccines do you think will have the best impact for your own population, for your own country? So what is in the future and what is the best for you? And you want to look at the different vaccines, and then we will see in the coming webinars, you want to go through a process to decide which is the best one and which one should be introduced when. Like, is it in 2028? Is it in 2029? So you want to go that. So I just want to mention an example. Ethiopia has done this exercise, and they decided that for the next 5 years, they would like to consider potentially introducing hexavalent, rubella, meningitis multivalent, and RSV. So that's what they think should be the future. If you look at optimization, optimization is trying to improve the vaccines, the schedule that are already introduced in your national program. So you want to consider either changing product, changing schedules, changing presentations, changing target groups to try to improve your program. It can be improving the program to get a better coverage, to be more efficient, to increase the impact, but it can be also a discussion to reduce the budget, for example, because one product is cheaper than another and the public health impact will be the same. So that's one is the future and one is now. And for example, I'm taking South Africa, our host today, regarding the discussion of PCV13 and switching, for example, from PCV13 to PCV10 in the context of new tenders and different prices. So that's what we mean by prioritization and optimization. So if we go one step further, prioritization is considered, as I said, for the future. We also don't discuss when we do prioritization regarding vaccines that are outbreaks vaccines or vaccines that we do in campaign only as a reactive mode. The benefit of the prioritization is really, as I mentioned already, is to make sure that the program is adapted to the real context of the country. That means you will decide which vaccine is the best for you in your country, for your population, rather than having somebody at global level telling you you should introduce this vaccine. The other thing is that you plan better because you are deciding that you want to introduce, for example, RSV vaccine in 2029. So you have some time before to plan, to discuss how the best way of introducing this vaccine in the future will happen. And you can also prepare the financial aspect of it and to be able to do some advocacy to convince, for example, the Ministry of Budget to invest a bit of money like that. And who should lead it? The prioritization should be led by the NITAG because the NITAG members are going to look at different evidences to compare the vaccine and to say this vaccine is better than this one for us in our country. Looking, for example, at the burden of the disease, the impact of the disease, the expectation from the population. So they will do that. But of course, they will do it with the EPI program to make sure that they are aligned with the reality of the program and the capacity of the program itself. So it's medium to long term. Usually countries consider the period of 5 to 10 years. So that's the future. The optimization, as I mentioned, is reviewing the current program. What do you have now? So you look at the products, the schedule, the targets, the presentation, the mode of administration, the coverage of the serogroups, and then you do a comparison between the products. You can compare, we don't want to compare here campaign versus routine, like is it better to do use this vaccine in a campaign mode or in a routine mode? This is a separate discussion, but we are just focusing on the element that I just said. The idea is to improve the program, to improve the coverage, to improve the logistics, to improve the demand, and also the cost. It's good sometimes because by switching from a product to another, you're going to reduce the money that you're spending, and you're going to be able to use this money to reinvest either in another vaccine or in another health programs. You also can improve the human resource. For example, if you reduce the number of injection like hexavalent, you may then relieve a bit the healthcare workers by having less work, and you can also improve the experience from the patient, the parents, by reducing the number of injections. This work is usually led by the immunization program with support of the NITAG because many questions of optimization still need the scientific and technical analysis of the evidence to, for example, if you want to move from PCV13 to PCV10, you're going to check if the main strains that are circulating in your country will still be covered, and that's the work of the NITAG. And this work usually is done in a short to medium term, and usually you consider the next 1 or 2 years when you do this element, okay? Sometimes, just to mention that some vaccines are in the between of prioritization of optimization. Typically, considering hexavalent is a new vaccine, but it's in reality a combination of existing vaccines. So usually it's in between prioritization and optimization, and the discussion can happen one or the other way for those specific things. So now I'm going to ask you again to participate to that list of questions. And I would like to have your opinion regarding each question, regarding is it a prioritization or is it an optimization based off what I just said. So again, I'm going to open the floor, and I want also some brave people to take a minimum risk of just saying what they think is the question that we're going to go through. So the first question is, should the country switch from PCV13 to PCV10? And when? Is it a prioritization or is it an optimization? So any participant, I see many hands that are up. I'm going to go one by one, and we have several questions, so I'm not worried that you will be able to respond. So I see first hand, Henry, if you want to respond to that.
Yeah, thank you, Sanusi. It's an optimization.
Henry, first, who
Yes.
are you? Where are you from?
Oh, my name is Henry Nagai. I work in Ghana, formerly with JSI. Now I work partly for the ministry. The first one, it's an optimization, and actually we try to do this in Ghana in terms of this switch. Yeah.
Thank you very much, Henry, for sharing the experience of Ghana. So you see some countries, many countries are already doing optimization, and they've been doing optimization for a long time. And now we are just putting a name on it and trying to systematize it so countries can do it one after the other. So the second question, the country is considering switching from measles only to measles and rubella vaccine, and when it should do that. So who wants to respond to this question? I'm going to take again the list that I have under my eyes, and I see Bianche Levancliffe. Who are you and what do you think? Oh,
Hi, Dr. Bianche Levancliffe from Cameroon, and supporting implementation of immunization in Cameroon, especially in Cameroon, and I'm leading the full portfolio planning in the South region.
so Bianche, I'm
So,
really sorry, the
as
connection is
concerned
very
the
bad.
need to
So I understood that you're from Cameroon. Please go ahead.
yes, so, I'm from Cameroon, and I work with a non-profit, which is Empower Women Foundation, and immunization activities, especially in the development of the INIS and Gavi food portfolio planning. So I'm representing civil societies in the NITAC for Cameroon.
Excellent. What do you think?
Switching from measles only to measles, I think it's a prioritization.
Tell us why.
Okay, I think it's a prioritization because sometimes it might be an intersection between prioritization and optimization from measles only to measles rubella, but now I think it will be more of prioritization, given that it's a new combination, it's a new skin concerning its safety, dosing, and a lot of things that need to do with new vaccine introduction. So it will be more of a prioritization than an optimization, because this is a new vaccine that is not yet in the immunization schedule.
Yeah. So I fully agree
So
with
it
you.
will mainly fall within prioritization.
So fully agree with you. This is indeed a prioritization question because in fact, you are introducing a new vaccine. You are considering introducing a new vaccine, rubella. So it's not just switching from a product to another, it's adding a new vaccine to the program. So you'll have to go through a discussion regarding that. So that's indeed prioritization. So, sorry, let me then ask the next question. Should we introduce, a country is considering introducing typhoid conjugate vaccine, TCV, in place of the polysaccharidic vaccine that has been used only during outbreaks. So do you think it's an optimization or is it a prioritization? And let me turn, I don't see a hand. Nassima, you had your hand earlier up. So now I'm going to ask you now. Nassima, what do you think about that one?
Yeah, good morning, Kemal. Good morning, everyone. So for me, this
Nassima, where are you
question,
from for the others? I know you,
yeah,
but
I'm Nassima Sai. I'm epidemiologist, and I'm from the Algerian NITAG. So for me, that should we introduce typhoid conjugate vaccine TCV in place of the polysaccharide vaccine used during outbreaks? It means that we didn't introduce this vaccine yet in the schedule, so it is prioritization.
Correct, Nassima. Indeed, it's a new vaccine and it's a
Yeah,
different vaccine.
I load my hand because I wanted to respond for the hexavalent vaccine, but yeah, you choose me.
I choose you for TCV. So
Yeah.
you will ask somebody else for the next one. But
Okay.
thanks, Nassima. This is correct. It's a new vaccine that is not introduced yet. It's completely different from the one that is used during outbreak. So yes, indeed, it's a new one. The next one, I'm gonna probably shift because I'm gonna respond myself because I already mentioned that the introduction of hexavalent instead of the current DTP IPV vaccine. This one is a bit tricky indeed because it's a new vaccine, but it's a combination of vaccines that have been already introduced in the country. So it's more an optimization. But some countries have decided also to consider it as a prioritization. Let me ask the next one. Moving from 10 doses measles vials to 5 doses. So just changing from 10 vials to 5 vials. And you know that doing that increase the coverage because the nurses, the vaccinators sometimes are reluctant to open a 10-dose vials for one children, for example, and they are less reluctant to do it for 5-dose vials, despite telling them that they should open it anyway. It's helpful for that. So what do you think? Let me see if there is any hand on that. Bianca, I already had you. Let me, Ali, go ahead.
Oh, okay, thank you very much. This is, I think, it's an optimization, and probably I think it's because of from 10 dose measles to 5, probably it's to reduce actually the missing opportunities. So that I think it probably is the optimization.
Correct, Ali. It's just a change of presentation. So it's not like a new vaccine. So it's really an optimization question. Another question that we are sharing here, the country wants to add a second dose of measles containing vaccine. Is it prioritization? Is it optimization? Somebody wants to respond to that one? Richard, go ahead. Who are you? And please go ahead.
Yeah, hi, Richard Lessels from the NAGI in South Africa, the South African NITAG. I'm based in Durban, South Africa. I think this would also be optimization because this is an already introduced vaccine, but we're thinking of changing the schedule.
Correct. So this one is also to show that a decision of optimization is not always just money, it's also sometimes to improve the impact of a vaccine. And we know that the second dose of measles containing vaccines improve the coverage and reduce the number of kids that are not vaccinated, but also the low responder to the vaccine. So that's an optimization for the impact. Next question. Countries considering the introduction of malaria vaccine. Some countries have done it, but a country is considering it as part of the routine immunization schedule in 2026. Is it a prioritization or is it an optimization? Anybody wants to respond to that? Simeon, go ahead. Simeon, we cannot hear you. Simeon, are you there? Okay, somebody else? Anybody? Okay, Roland, go ahead.
Can you hear me? This is a prioritization because it's a new vaccine and you want to increase the uptake in locally safety. So it has to be prioritized. Thank you.
So we can hardly hear you, Roland, but I understood that you said it's a prioritization. It's a prioritization because it's a new vaccine that is not in the current schedule. So you're correct, Roland. Perfect. Last question. A country is considering introducing meningitis pentavalent. Same question. Is it prioritization of or optimization? Anybody wants to respond to that one? I have Elvis.
Yes, good afternoon. I'm Elvis, a microbiologist. I'm originally from Cameroon, based in Switzerland. It's a optimization because we already have meningitis vaccine and already used, and we want to use a pentavalent one.
So I would say that you're correct, because the MEN 5 is for now, at least for the Gavi eligible countries, is reserved only for countries who have already introduced the MEN A, which is most of the countries in sub-Saharan Africa. So indeed, it's an optimization to move from one to another. So thanks for that. So thanks, you got all correct. So I think you really understand clearly the difference between the two and sometimes the intersection. I just want to add one thing. And we're going to go, but I'll add that later. Sorry. Let me hand over to Jason for the Q&A section. So, Jason, back to you.
Yeah, thank you. Thank you very much, Kamal, and thanks, Ben, for these very informative presentations and somewhat also very provocative. So I guess we have a lot of questions and comments from the participants. I think Ben did a very good job in terms of going through the journey of national immunization program, the 51 years, the impact these vaccines have had, and the complexities that we are facing now, including the decreasing funding. So I'll be moderating these Q&A. So please, if you have a question or comment on the two presentations, please put up your hand or use the Q&A icon at the bottom of your screen. I think now we can open it up. If you want to comment, please just put up your hand and introduce yourself very briefly and be very specific with your presentation because we have very limited time. Let me see. Yes, I see Soyeon Sim.
No,
Wait, sorry, I forgot to introduce myself. My name is Jason, formerly with WHO. I'm now a consultant with the niche, and I'm moderating this Q&A session. Sean, please. You can unmute and make your comment very briefly.
that was a mistake. Sorry, Jason. Please
Oh,
go
okay.
ahead, colleagues. Thank you.
Okay, I don't see any hands. And Kamal, I don't know whether you're looking at the Q&A session, but
Yeah.
I see a question from
I can
yes.
look at the one from Godfrey regarding the context.
Yes.
And,
Yeah,
many
the impact
countries,
of funding. Exactly.
Yes.
The impact of funding on prioritization and optimization. If you can quickly respond to that. There was some comment about the available resources also for the prioritization and optimization. I think there's a comment from Evans also, Mkoe. If you can maybe, in the meantime, as we wait for colleagues to put up their hand, respond to those three comments. Kamal, over to you.
Yeah, just to say that indeed the past few months have really impacted the way we were doing the work in the past, because the funding is really reduced. The several donors have reduced their bilateral and multilateral support. So not only countries have seen some bilateral aid drastically reduced, but also Gavi has seen the budget goes down. So the next few years will be a bit difficult because there is less money than we had in the past. So that means that countries will have to decide which vaccines are very important to them. Vaccines that are already in their schedule, so they will have to discuss how they can change the current program to try to find some savings to be able then to either introduce new vaccine or to improve the coverage. Or they will also have to look at the future and decide to introduce vaccines that are really relevant to them, knowing that there will be less funding and that they will have to decide which one really needs to be introduced regarding the funding that is available. That indeed, there is a discussion happening at global level with Gavi members, WHO, UNICEF, Gates, Gavi Secretariat, and others, to discuss the best way to do that. And indeed, prioritization and optimization will be a key element of this process that Gavi will put in place for Gavi eligible countries. Middle-income countries have been doing that for a while, but it's true that they will have to do it even more because of new vaccine introduction that didn't happen yet. So that's, in a nutshell, what I'd like to respond to this first point.
Thank you very much, Kamal. Maybe comment on the available resources that could help colleagues with further reading on the concepts of optimization and prioritization.
So I believe that the first support that you're going to get is typically this webinar and the webinars that Niche is organizing in the coming weeks. I think it's important, if you can, to attend those webinars because it will give you an understanding of what tools are available to do prioritization and optimization. Those tools are for prioritization, they are fully available and online, and several countries already did those prioritization exercise. Niger, DRC, Uganda, Guinea are doing it, have done it or are doing it currently. Some countries have done that alone without external support because the tools are really adapted for the NITAGs to do it on their own. Optimization is a bit different. There is an ongoing work at global level led by WHO and UNICEF to develop optimization tools for specific questions like PCV, HPV, and others. So they will come with tools available in the coming weeks or months, and those tools will be made available to the countries. Regarding getting more support, this is a discussion that you're going to have with the WHO, UNICEF, Gavi, and others. And there is an ongoing discussion at global level on how, for Gavi-eligible countries, this support will be provided to countries. The final decisions regarding that are not done yet, but they will happen. But still, WHO and UNICEF and networks like Niche will be key. GSI and others will be available to provide some support. But I see that Louise raised her hand. Louise, if you want to continue on that topic, please go ahead.
Well, I would like to flag regarding immunization decision making. We had a session at SAGE in March 2025 where we presented the progress of the NITAGs. We also showed that the Secretariat is still under-resourced in most NITAGs. So having a dedicated staff to ensure that the evidence review process is thorough and intensive as required. So SAGE called on countries to increase their domestic funding, especially to support the Secretariat of the NITAGs. And this will be critical if we want to ensure that the new scope of work, extended scope of work that we are asking NITAGs to do can be guaranteed by the NITAGs. So the support that we provide through WHO, through Niche and other technical partners is really to ensure that the NITAGs have this capacity to do the evidence review process. And we're really encouraging you to link up with local institutions to help generate the evidence or to capitalize on the evidence generation. I think this is really critical because we can have as much global evidence and regional evidence available. At some point, we need to rely on the countries to contextualize the decisions.
Thank you very much, Luis, for those additional comments.
So, Jason, I see a question. If you want me to respond to the question from Gordon in the...
Oh, yes. Yes, please. Yeah.
So Gordon is asking, in case where a vaccine is already in the schedule but underutilized due to a low coverage, and we know some vaccines like that, would efforts to improve uptake still fall under optimization or prioritization? So for me, no, this is not optimization. This is not prioritization. This is not prioritization because the vaccine is already in your schedule. This is not optimization except if you're considering changing the way you're using this vaccine in terms of changing product or changing the schedule, like one dose instead of two. And in that case, it's optimization. Let me take the example of HPV. HPV was a schedule of 1+1 until SAGE, WHO SAGE made a recommendation that one dose could be used in countries to improve coverage and to improve the impact of the vaccine. So in that case, it's true that switching from 2 doses to 1 dose is an optimization. But if the vaccine, and let me take example of measles vaccines, measles containing vaccine, if your coverage is low and is not sufficient, you're not going to change product. The main concern is programmatic, how to reach more kids. And this is, I would say, something that should be led by the EPI program, assess why the coverage is low, what can be done. Is it a logistic problem? Is it a services problem? Is it a zero dose, how to reach kids, all that? And those analyses will be done by the EPI program. Sometimes you can go to the NITAG to get advice, but most of the time, this is something that is managed at the immunization program itself. And that's why I would say in that case, it's not really an optimization. So it can be, but it's most of the time it's not. And Jason, if you allow, I see that Folake is raising her hand probably on that topic.
Yes, thank you very much, Kamel. I just wanted to come in and say that this is the description of a low coverage is really programmatic. And this is where you want to continuously identify where you have the low coverage, the underlying reasons, and then look at the solutions that will be very much tailored to the context. Is it a conflict? Is it due to demand? Is it due to service supply issues? And then your solutions will come from there. So the solution may involve an optimization. For example, if it's measles coverage that is low and you find out the major reason is because of or contributing reason is because of the reluctance to open vials, then a switch to a 5-dose vial might be part of the solution you want to undertake. So just to support that response.
Very good example of measles, indeed. That's one element of the response, but one among many programmatic consideration. Thanks, Folake. Back to you, Jason.
Thank you very much, Kamal. Thanks, Folake. I don't see any hands, and I think we are running out of time, but I think Ben is still online. So maybe for Ben, just as we wind up, you took us through the journey of the National Immunization Program and referred to the decade of vaccines and IA 2030. And I think we all know that for the decade of vaccines, I think we missed most of the targets because I think the targets were quite ambitious. And with the IA 2030, I think we're trying to come up with what we think are more realistic targets. And given that we only have five years to this cut down, in terms of the scorecard at the regional level and perhaps also the countries, some of the countries that are participating, where are we now in terms of meeting those targets? Maybe very briefly as we wind up. Thank you.
I think Jason, in terms of most target, we're still behind, but I think in terms of new vaccine introduction, I think that is going on pretty well. And I think one of the positive I could just comment briefly here is the issue of partnership, which I think especially in our continent has been gaining momentum. And for initiative like NICH, now we're working with University of Geneva and Choices. It is through this kind of partnership we are able to strengthen the program through making sure that adoption of tools that are available is quick, and also making sure that we provide all the necessary support to NITAGs, because we see NITAGs as very essential in ensuring that these targets are met. So as much as there are some lack of hitting this target, I'm very optimistic, and I call on further strengthening and more coordination of partners in the support of the work of NITAGs. Thank you.
Thank you very much, Ben, and thanks, Kamal. This has been very, very informative, and I hope that the participants, particularly the program managers, the chairs of the NITAGs and NITAG members, really the take-home messages from this presentation. So I think we'll transition to the next presentation. Just to say that the Q&A is still open, the chat is still open. We have a number of experts in the panel. I saw Dr. Amani from WHO Afro and CD and other colleagues from WHO and other partners in the panel. So please feel free to pose questions to these experts. We'll continue to follow up the comments in the Q&A session and the chat, and we can respond to you directly. So we hope that this interaction will continue. But I think for now, we just want to thank Ben and Kamal and Folake and other colleagues who really responded to the comments that came from the floor. So thank you very much. It was really very, very informative. Thanks for your time.
So thanks, Jason, and it's still me talking. So I'll continue. I have a few slides. So just to say, so we understood now the difference between optimization and prioritization. So let's see now when you should do one or the other, when those processes should be put in place. So very rapidly. So the first thing that you have to consider, sorry, I'm having some troubles here. Okay, so the first thing, there is a strong recommendation from WHO to do an NIS, a national immunization strategy, and I believe that most of the countries either have done it or are in the process of developing their national immunization strategy, which is what they think should be done in the coming years. So when you develop an NIS, before you should, in theory, before you do the NIS, you should do a prioritization because you should know what you're planning to introduce in the future. If you already have done your NIS, you can update it when you will have done the prioritization, because you can update, because the prioritization will really help you to understand what is the vaccine you want to introduce in the future and which one when. So that's why it's important to do it and to update your NIS. There is also a possibility of doing the prioritization when you will do your midterm review of the NIS, and the optimization should be probably conducted at the same time. There is also, it's important to conduct those processes depending on when you have your budget and funding cycles, because deciding to introduce a vaccine in the future or deciding to change product will have an impact on your budget. So it's good to make sure that you are aligned and that you conduct a prioritization and optimization before you do your budget funding. So that's also probably another opportunity that you can take to conduct that. Another opportunity is also for countries that are buying vaccines directly. When you're about to publish a tender for supply, for procurement, it's good also to do those exercises so you know exactly what you're going to need in the future or what switches of vaccines you're going to do in the coming years. So it's important to do it if you have tenders process. The last one, when you do an EPR review, for example, you reviewed your program and you see that there is some issues like Folake mentioned, you have a measles coverage that is low, and you think that switching from a 10-dose vials to a 5-dose vials is something you want to do. So that's sometimes a conclusion of the EPR review. That's also a good opportunity to review again your schedule and look at potential optimization. And lastly, there are different events that can happen at global level that can also push you to do an optimization or a prioritization. For example, if there is a new WHO SAGE position paper, I mentioned typically the HPV. When SAGE said you can move from 2 doses to 1 dose, that was an opportunity for each country to look at their HPV program and consider moving from 2 doses to 1, which is an optimization, but also to consider which product should be used for this 1-dose program. So that's an opportunity coming from, for example, SAGE. There is also Gavi policies. If Gavi tomorrow tells you we will be able to support RSV introduction in countries in Gavi 6.0, and we will open the possibility for countries to apply. That's a new opportunity, and you want to look again at your prioritization. If you already introduced RSV in your prioritization, you may want to consider changing maybe the date of introduction based on the new Gavi policy. But there is also, for example, a new vaccine coming to the market. Let me take an example of PCV. A new vaccine is available from a producer, for example, from India, that is much cheaper than a vaccine producer from another country. So you want to decide, okay, this vaccine is cheaper, is pre-qualified from WHO. So if I switch to this vaccine, I will be able to save a lot of money. So let's consider switching to this product. So that's something that is happening in the market that will impact your decision making. So that's when you can trigger the prioritization or optimization. And let me go now through the roles and responsibilities of prioritization optimization. I already mentioned that, but there are two main players in this prioritization and optimization. Those are, of course, the immunization program, the EPI, and the NITAG. Okay, so the EPI role is really to assess the performance. For like I just mentioned, when you look at a problem like a coverage problem or a cold chain problem or an HR problem, this is the EPI role to look at the performance of the program and to try to improve it. The EPI is also the one who plans and implement the immunization strategies and service delivery. They are the one in charge of the program. So they are the ones who need to plan to make sure that the planning is happening, to make sure that any change of the program is implemented and has a limited impact on the existing program. They are also the ones allocating the resources in terms of vaccine allocation, but also human resource. So they have to allocate, but they also have to optimize, because there is no country in the world who has unlimited budget for health. So everybody has to manage with a limited pot of money. So we have to make an effort every time to try to improve, to optimize the use of resources that we have to have the biggest impact. They are also the ones setting the operational priorities. For example, the EPI is the one who's going to tell you next year we're going to have a campaign for yellow fever. Next semester, we have a campaign for polio. So all that will also impact the decision regarding optimization and prioritization. And they are the ones communicating with all the stakeholders at subnational level, at global level. So they have this role that is important. The NITAG on its side is the one that is reviewing all the evidences and data, mostly the burden of disease, the cost effectiveness, the safety, before making recommendation to the EPI and the Ministry of Health regarding changes of the immunization program. They develop recommendations for new vaccine introduction, but they also have a look that is an independent look, which is very important, so they can guide the Ministry of Health having an independent look. They are not biased, they are not engaged in the program itself. So when you look at the prioritization and optimization, the EPI is the one who's going to lead the prioritization. First, because they are the NITAG Secretariat, so they can they do this work, but they will also support the prioritization because they can share all the constraints to the NITAG and say to the NITAG, okay, you are telling us that we should introduce RSV in 2026, but unfortunately in 2026, we are already introducing, for example, HPV and malaria vaccines. So it will be very difficult to introduce another vaccine. So please, let's postpone that. So that's where they can share the constraints. They can also help the NITAG to identify where the evidences are, because they are the ones working with many people in the country. So they will know, for example, oh, yes, we have data regarding cervical cancer done in this hospital. So we will provide those data as the secretariat of the NITAG, so you can do the prioritization with all the data that you have. And they can also translate the priority and the sequencing into strategic planning, because the EPI is in charge of the NIS. On the other side, the prioritization is led by the NITAG, because the NITAG is looking at the data, They are looking at the evidence, so they can help to decide which timeline is considered for the prioritization, 5 years, 10 years, which vaccines should be considered. Let's not waste our time with vaccines that we know that we're not going to introduce in the future, like Shingrix, for example, for the zona, and also decide which criteria they want to consider to say that a vaccine is more important than another one. So they will support the evidence collection, they will support the evidence analysis, and they will review all the evidence, and they will rank the vaccine, saying this is the vaccine that we absolutely need to introduce in the future. And the second one is less important, we can do it later. And the third one is probably even later. So they can do this sequencing. When it comes to optimization, it's the opposite. The API is the one who's leading the process because they are the ones who are managing currently the process, the program itself. So they know, most of the time, they know which optimization questions are critical, like changing the size of the vials, like changing product because one is cheaper than the other one, changing the schedule like the HPV because with one dose we will have a higher coverage. So they know already which topics should be discussed, and they have all the information, most of the information that can be used for the optimization. They can collect the data, they can organize all that. Sometimes they will ask the NITAG to help for an optimization question because they will need the NITAG to look at some scientific question. And let me take an example that I already mentioned, the PCV. The EPI program may consider changing from PCV 13 to PCV 10 because it's cheaper, but they will need to ask the NITAG, what do you think in terms of coverage of this PCV 10 regarding the strains that are circulating in our country? Is it okay? Is this PCV 10 still covering most of the strains that are circulating in our country? And by switching, we are not taking any risk of not covering the strains that are circulating. So that's where the NITAG will have an important role. So the NITAG may look at many questions like that and support the EPI in its decisions regarding optimization. So very lastly, I don't know how much time I have, but I want to mention that the tools that we are proposing to do prioritization and optimization are based on what is called MCDA. And many of you are familiar with the ETR, Evidence to Recommendation tool, that is used by a NITAG to consider a specific question regarding introduction of a vaccine. So MCDA are tools that are using multi-criteria decision analysis. That means you look at different criteria. You have a question, and you use different criteria to score the different possibilities, and at the end you discuss the criteria based on the data that you have, and you make a decision. So it's really logic approach. The question is, should I move from a PCV 13 to 10? The criteria are going to be, what is the burden of disease? What are the strains that are covered by PCV 10 compared to PCV 13? And what is the cost and all that. Then you rank based on the results of the questions. You rank, and then you make a final discussion and you make a decision. So that's MCDA. It's a very known approach that is used for ETR. This is the approach that we are using here for the prioritization tool, which is called the NVI-PST. So I mentioned the ETR that you're already familiar with, but the additional tools that we are talking now for optimization and prioritization, one is called NVI-PST, which is the tool that is proposed for prioritization, future vaccine. So the tool is fully available, and we're going to go through it in the next webinars. And there are tools that are under development for optimization, that are tools that are talking about specific questions like PCV, HPV, measles. And so we have many questions that can be answered using MCDA approach. And those tools are under development currently by WHO and UNICEF. And those tools will help you to respond to one specific question, like I mentioned, PCV 13 to 10, HPV 2 dose to 1, etc. All those questions that are optimization. And that will use the same approach of MCDA. And hopefully we will be able to have a package that will be NVI-PST and the optimization tools in one set of, one package that you will be able to use for the optimization and prioritization questions. So we will go through those tools in the coming weeks with the webinars that Niche is organizing. So I think we reached the Q&A, and I'm handing over. I'm not sure if it's Louise, I think, who's managing the Q&A section. Thanks.
Yes, I am managing, and for now I see one question regarding HPV clarification, if the one dose is a prioritization question or an optimization.
So I would say that HPV discussion is if the vaccine is already introduced in your schedule, this is not anymore prioritization, okay? Because the vaccine is already introduced. So if you already introduced HPV and now you are discussing girls only or girls and boys, I would say it's not an optimization question. It's really a strategy question, because the reason why there is a recommendation to introduce boys is to improve coverage, because you cover the whole population. You don't have the problem of focusing on vaccinating only girls, where you know that it has been sensitive in many countries. So by doing boys and girls, you eliminate these sexual relations discussions. But then you have to assess the impact, because for now, SAGE still recommends to focus on girls, because studies have shown that if you focus on girls for now, you will impact more the cancer by doing that for now. And then in a second time, you can introduce boys to reduce the circulation of the virus. But this is a work that has to be done at country level to compare the two strategies, girls only and girls and boys. And there is also a cost impact, because if you include boys, you double the population. So some countries have considered that by moving from 2 doses to 1 would be a good opportunity to vaccinate boys also. But again, it's a decision that's happening at the country level. For me, this is not prioritization, neither optimization. This is a discussion of an ITAG, looking at different strategies and different impact of the approaches. So for me, it's neither the one or the other.
And so regarding, and Kamel, we can take this with Adija and with CD. Nigeria has introduced HPV and they introduced for girls and boys, but the coverage for boys is quite low. So Adija or CD, would you want to comment on that?
Okay, good afternoon, everybody. I don't know, do you hear me?
Yes, we can.
Okay, I think for HPV vaccination, I think as Kamel said, the main focus should be the girls, because if you have a coverage like 70% among girls, you have a huge impact in the cancer, but also in the HPV infection. So there are many studies on that. And the information I have that Nigeria now switched from the 2 doses to 1 dose for HPV vaccination. So Nigeria is a very big country, so the cost impact is very important. The NITAG should look at the cost effectiveness of vaccinating boys and girls and versus vaccinating only girls. And you have not HPV vaccine only, you have other vaccines that are very costly. And so this is why the NITAG is important, to help the immunization program to make the best decision based on the local context.
Thank you, CD. As we're running nearer the end, I would like to take the questions that is on the Q&A. So Kamel, you mentioned that the EPI should lead the evidence collection, but this is assuming that there is sufficient secretariat support to do that. And as I mentioned, many NITAGs don't have the dedicated support for the secretariat, and this impacts the evidence collection. And so, meaning this would who would lead this evidence collection in the case where there is no support to the secretariat or the EPI?
So I think, Louise, you probably could respond better than me on that. But if you want me to share my thoughts, I think we've been pushing the global partners to support NITAG Secretariat more because we really see an added value of a strong secretariat of the NITAGs, which is most of the time managed by the EPI program. So we still express this need for more support to be provided for the secretariat. There is an ongoing discussion at Gavi, for example, for the Gavi eligible countries, regarding the need for countries to do prioritization and optimization in the coming month because of these budget issues that Gavi is facing, and to have countries to lead the process in terms of deciding which vaccine they want to have in their program. So that's why the prioritization and optimization will be key, and that's why strengthening the secretariat will be key. So hopefully, we hope that Gavi will be able to support that. Otherwise, if there is not enough support for the secretariat, in many countries, we've seen also some NITAG members helping and taking one topic, for example, when it comes to prioritization and you have identified 4 or 5 vaccines, we ask the NITAG members to explore the data and to reach out to people to find data that can be used for the comparison. So that means that the NITAG members dedicate a bit of their time to do that. This is not a long and heavy process, but it's true. It's some work, additional work. But in countries where we have worked, most of the NITAG members have done it, and they've been very supportive to do it. So that's the other way. But Louise, I'm sure that you can complete that.
Yeah, to complement, so I think working with local institution where they exist or university where you have NITAG members and using some of the PhD students could be also a good option. Regarding using technical partners, Niche is also very well positioned to support the data collection, and they have a librarian that can also help generate and prepare some technical dossier that would expedite this process of evidence collection. I see CD has his hand up, so I will let CD complement.
Thanks, Louise and Kamel. I think the NITAG work is not only for the secretariat in terms of collecting the data. So we have all the partners should be engaged in this process, like what we call the licensed members, or WHO, UNICEF, and others, to bring together their effort to collect evidence. Like if you take all the evidence on supply chain vaccine availability, UNICEF should bring its data on that. WHO, all the vaccine efficacy characteristic and program data should also help on that way. So, and really congratulations to the Niche who is producing, helping the countries in that side, in addition to the effort made by the regional office and country offices.
Thank you, CD. And I think, yes, the better coordinated and liaised the NITAG is, the better access to evidence you will get from UNICEF, from WHO, and from technical agencies to provide the evidence that you need for your prioritization or your optimization exercises, or both. Before I hand over to Folake for the closing remarks, in the chat, Raimonde and Petronella have provided a link to a survey. This is just to collect feedback. It's a series of webinars, and so we'll try to incorporate your feedback to improve the following webinars. And now I will hand over to Dr. Folake.
Louise, thank you so much. My name is Folake Olainka, and I'm a consultant with GSI on the choices of vaccine prioritization and optimization work. I also am a former SAGE member. I just finished a 5-year tenure, and also a former WHO Afro-RITAG member, where I served for many years for the African region. Most recently, I served as USAID's Global Immunization Lead. What an outstanding webinar session today. Thank you so much to all the speakers and all the NITAG members who have participated today, as well as our partners that have joined us. The overview of the new vaccine introduction prioritization support tool and optimization program is one of a series of webinars that is intended to deepen NITAG ability to adapt and use the tools designed for evidence-based decision-making in our countries, especially in an increasingly complex vaccine landscape. Just a quick reminder to kindly complete and fill out the pre-session survey. The link is in the chat if you have not already done so. And again, just to wrap up today, we've had the sessions on the journey of the expanded program on immunization, now called the Essential Program on Immunization. We've walked through the definitions and core principles around vaccine prioritization, optimization, looked at the triggers for decision-making, as well as the actions. So once again, on behalf of Choices 2, project led by GSI, all our partners, NISH, WHO, DEFCAT, really thank you all once again. We look forward to seeing you in the next webinar, which for the English will be on the 22nd of October. The French will be on the 23rd of October at the same time at noon. For those who are interested in the Francophone version of this same webinar, this will be held tomorrow at the same time at noon UTC. So once again, just thank you very much for your excellent engagement and participation. Have a wonderful rest of your day.
Thank you, Folake. Bye-bye, everybody.
Thank you, Fulake. Bye-bye, everybody.
Thank you.